Now we are focusing on the clinical part of the covered area of the upper limb, which is going to be like short and crisp. Not much of detail of this gross anatomy we are going to talk about. We talked about like previous sessions in about the shoulder joint and the clinical problems related to that. So that for that reason I am skipping that particular clinical part of the shoulder joint, which is already been covered. I just do not want to re-utter those things. So there are some regions in this upper limb that we have to focus on to understand the clinical problems based on these upper limb clinical problems. There are some neurological deficits that you need to focus. There are some like vascular deficits or vascular problems that need to be taken care of. There are some issues related to the muscular problems in the upper limb that we have to understand, learn and groove in. Now, there are situations that we may not be able to comprehend the whole thing clinically because we do not know anything about, just like we are learning just like a little bit or very little about human body, and we haven't have any exposure to the patients. When we were young, these particular clinical concepts are covered in the clinical settings like surgery, orthopedics, etc., etc. Even when we were doing like a postgrads or doing house jobs or clerkships, we learned those things by seeing the patients and reading the books. For you guys, you are just like being exposed. This is called early clinical exposure. So we are just exposing this particular anatomical facts based on like clinical scenarios, so that you have something in your brain whenever you are going to see the patients in the clinics. You can always come back and see this particular content. It's not that 100% you are going to learn and 100% you are going to comprehend about this particular clinical problems. Now, clinical problems related to this particular upper limb involve some nerve injuries, but just like I want to skip to reach to this particular injuries in the brachial plexus that we have learned, like we have this network of the nerves which is present in this particular cervical and the upper thoracic region, spinal nerves forming this particular network, and in this particular network there are some injuries which is happening within this particular brachial plexus itself, and that is yielding some of the diseases. Two of these particular brachial plexus injuries that is very commonly been tested in examination that we have to learn and understand, and clinically too we have to understand this particular thing coming to us. Now, to understand this particular Erb-Duchenne paralysis, before that we have to understand what exactly going on. So this is what we have learned so far. This is a spinal cord that you are seeing from the part of the spinal cord, right side, left side. There are spinal nerves that are coming. These spinal nerves makes a network that we call them as brachial plexus, and they are going to split and just like reunite again and again to give rise to the nerves which is going to supply all the muscles in the upper limb. This is the basic idea of the brachial plexus and brachial plexus nerves. Now, what do we mean by this particular brachial plexus injuries? At the formative level, when this brachial plexus is forming this particular plexus, there are some injuries. So, which is going to rip off some of the nerve fibers. That is going to form some nerves. So, that is going to fall on the nerves which is eventually going to be supplying the muscles. So, this is a kind of like a root problem of a nerve injury, where at the beginning level we have a hit. Now, this particular Erb-Duchenne paralysis, or next time we are going to talk about Klumpke's paralysis, these are brachial plexus injuries. That mean that there are injuries high up in location. That means right from this particular region where these particular nerves have exited, somewhere maybe these particular nerves have like gone up or ripped off. Now, to understand this, we have to understand how this particular nerve injury have occurred. The common problem of these particular injuries that we are going to learn here, we call them as Erb-Duchenne paralysis. Most commonly, we seen that this particular problem happens during childbirth. Now, during childbirth, what happens? There is a face presentation or head presentation. That means the fetus is going to come through the head. Now, during that particular childbirth process, we assist the like a childbirth process, right? So we just like allow this particular or help this particular fetus to take it out and pull it out and assist it. So we call them as assisted labor or assisted childbirth management. Now, sometimes we get like overexcited, sometimes we get like over enthusiastic. That's what this particular problem may happen. Now, see that this particular kid is presenting with the head. Normally it does. Now this face or head presentation, this is coming, and this particular movement of the head coming up, it taking some time. Now during that time, we sometimes get overexcited or over anxious. We grab this particular fetus head and pull this thing up. Now this is what that makes this particular problem. So if we just like early in putting a traction, whenever this baby is coming out, we might rip this particular nerves which is present in the neck region, especially the upper nerves. This is commonly happens during the childbirth process. Unknowingly we do that. So this is a common problem that happens during the childbirth, and this particular problem happens like we do not understand anything about this, what this particular problem is there. So we have pulled this particular baby out of this, and we are very good, like feeling proud about that we did a very good job pulling this baby out, is crying and doing fine, and next day you go around and baby is sitting something like that. Hey, move your hand. You don't understand. Oh, you're angry with me, maybe. But the baby never like put the hand out like this. So this is a problem which is inadvertently or unknowingly done by us. So this is what we call them as Erb-Duchenne paralysis. So what happens over here? During this traction, we pull this particular nerves, rips these things while pulling the head out, and baby is extended hand like this. This particular hand positions, we call them as policeman tip hand. That means if you are going to bribe some policeman, you cannot just say, sir, takata nin, chhede din. Sir, takata niye chhede din. So you have to just like cover it up. You cannot bribe an official person like open, like in a place. They will say, no, Jan. So he's not taking the money, and again he is not letting you go. So you have to just like be like something tricky in bribing a official person, right? So you have to just like bribe it. I do that most of the time. I never drive in a more normal civilized manner. Like every time I break that signal, every time I just like override this particular steps, and every time daran doctor babu kothay gacchen, patient ache ki koren doctor babu mure jacche college doctor babu eram korle ki kore hobe রাস্তায় the patient মরে যাবে তুলে নিয়ে চলে যাব হাসপাতালে. So things happens like this, and we have to bribe. So this particular position, we see that this particular Erb-Duchenne paralysis, what happens, this particular nerves gets ripped off like C5, C6, and the union point over here which splits into like upper trunk, lower trunk, and again this nerves which is coming suprascapular nerve and nerve to subclavius. This point where we see the 6 nerves are coming out, this point is mostly ripped off. And the nerves which is coming over here are going to supply few nerves. What nerves are going to supply by these nerve fibers which is crowding over is going to supply this particular axillary nerve, it's going to supply the musculocutaneous nerve, it's going to supply nerves to subclavius. Resulting in these particular nerves are not going to work, so the muscles are not going to work. So leading to this particular deficiency in a position like the arms will be like a plastered to this particular arm up to the body, and it will be medially rotated and it will be extended like this. So this extended arm will be there, which will be close to the body, medially rotated, and it will be staying like this, and it will be appearing like giving some kind of tips. So these particular positions we call them as Erb-span point or this particular problem. Now what we have to understand, what basically problem we have with the nerves if you have ripped off with these particular things. We have this particular axillary nerve injury, we have this musculocutaneous nerve, we have the suprascapular nerve, subclavius nerves, they are ripped off. Now we have a loss of shoulder movement. That means this particular individual who have this particular problem, they will be arm hanging by the side, medially rotated, elbow extended, that means arm extended, shoulder A double deducted close to the body, and forearm pronated, which is going to have this particular clinical presentations. We call them as waiter tip or policeman tip position. Now what happens over here is that loss of abduction, that means arm cannot be moved, that means supraspinatus and this deltoid is not going to work. That's why this is going to have this particular paralysis. Next is that if you have loss of flexion, that means the flexure of the elbow joint like BBC, biceps, brachialis, coracobrachialis, they are not going to work. So likewise the brachiolarialis is there, so it is like extended in the elbow joint as well. Next is loss of rotation, external rotations because of this particular supraspinatus, infraspinatus not going to work. This medial rotations of this of this particular shoulder joint will be there because lateral rotators are not working. So, resulting in this particular positions over here. So, what we have to understand at the level of injury where it is, how this particular injury commonly happens, what are the nerves that are going to ripped off, and what are the clinical presentations. So, that means how the arm is presented and explain why. That means arm is A double deducted, medially rotated, shoulder joint movement is not there. So, explain it like arm is extended because we cannot flex it. Who is flexing the elbow joint? BBC. BBC is not working, that means which nerve is not working? Musculocutaneous nerve. Arm cannot be A double deducted, that means the deltoid and the supraspinatus is not going to work. So, that is supraspinatus nerve and this axillary nerve, and along with the teres minor and along with this particular supraspinatus is not going to work. That is why this particular positions has happened. So, this is what you have to write and explain. So, once again, so this particular problem you have to write it like when commonly happens, like you may have a fall like this where this neck is super extended or fractured like this, or it commonly happens during the childbirth when this particular head is too much of pulled out, and this particular thing results in arm drops by the side, medially rotated, elbow extended, shoulder A double deducted and forearm pronated. There is a loss of abductions, muscles which are not going to work, you have to explain it. Next is other thing, we have seen this particular injuries in the Erb-Duchenne paralysis involving the upper trunk. If you have this particular same kind of injuries involving the lower trunk, we have this particular problem, Klumpke's paralysis. So, what commonly happens with this particular Klumpke's paralysis? This happens in case of the fetus, like if you are again assisting this childbirth, the fetus is presenting with the hand. Sometimes instead of the head, the fetal hand is coming out. We call them as hand prolapse. So, if the hand is coming out, you hold that hand and pull it out. Oh, shake hand, come out, come out. It's not the way we are going to deal with it. So, again, you are pulling this particular thing. It's not going to work. It's going to work and going to eventually rip up these lower nerves, CAT1 nerves. So, they will be knocked out. Sometimes happens you are just like a too adventurous, climbing and hiking, slipping somewhere and falling and then grabbing some trees and hanging by that, and again overextended lower part of the brachial plexus. Again there is ripping of this particular nerves which is like CAT1. Now CAT1 going to supply this particular nerves which is going to supply this particular ulnar nerve domain. So this particular person who has this particular problem with this Klumpke's paralysis, inferior trunk CAT1 is having a injury or insult to this particular ulnar nerve injuries, or ulnar nerve is not going to work. Then summarily it presents with the claw hand deficiency. That means small muscles of this particular hand is not going to work. So, if you ask this particular patient who has this particular claw hand to make a fist, they cannot do it. So, if you ask you to make a fist, they will make a fist. But with a claw hand injuries where this ulnar nerve is not working, the patient makes this. Try to make a fist, but makes a claw. And this particular claw is a partial claw, not a full claw. Some part of the hand is making adjustment and some part is not. So, this particular element we call them as claw hand deficiency, along with this particular some neuro deficiencies on the sensory part as well will be there. So, this particular injuries with the Klumpke's involves in the inferior trunk or the lower trunk of the brachial plexus CAT1 domain, and this particular injury is maybe just like undue abductions of the arm, maybe just like you have just like a pulled it too much high, or maybe just like a pulled the arm during the hand prolapse or arm presentations, and resulting in the CAT1 which goes to serve the nerve fibers into this particular ulnar nerve, and the ulnar nerve deficiency will be there in forms of claw hands. So, short muscles of the hands are mostly affected. So, if you ask the patient to make a hand fist, whenever he is going to do that, he is going to make a claw hand or claw hand deficiency. So, Klumpke's paralysis and Erb-Duchenne paralysis is your exam questions. You have to prepare that very well. So, you have to have a clear idea which particular nerve fibers are is ripped off, what are the clinical cases where you might have these particular problems, and what exactly the problem is and where exactly the problem lies in terms of these particular clinical problems. So, 4 mark questions are there. whenever you are going to do a clinical questions or any questions in anatomy, try to do a schematic short diagram along with the explained thing. Alright. So, this is about this particular nerve injuries that we have talked about, claw hand and other injuries to the Erb-Duchenne paralysis. Now, other use of this brachial plexus nowadays, like very commonly we use that brachial plexus to do surgical procedure. We call them as brachial plexus nerve block anesthesia. So, we have seen this particular brachial plexus which is going to supply the muscles, and these particular nerves are going to supply this particular skin as well. So, instead of giving a wholesome anesthesia, which is like sometimes the patients may not have a clinical fitness to give a generalized anesthesia, we give a regional block or regional anesthesia. That means the upper arm or right arm we are working, we give this anesthetic drug on the right arm only, rather than giving a full knockout dose of anesthesia. So, for that reason we have to know about the brachial plexus nerve, where exactly these particular nerves are. We draw some like anesthetic drugs and we throw the drugs over there, either above the clavicle, identifying these particular positions of this particular brachial plexus, piercing the covering or sheath brachial plexus have, brachial plexus sheath, and maybe through the axilla we can just like tap these particular nerves like this and throw the drug and achieve an anesthesia, do a procedure. So, this particular brachial plexus block is an anesthetic procedure where we are going to throw some agents or chemical agents which is going to block these particular nerves, and this particular blocking of the nerves leads to paralysis of the muscle, and the skin sensation as well is not there. So, that we can cut this and do the surgery and again come back with this particular problem. So, upper limb anesthesia is kind of very commonly nowadays very popular, this particular brachial plexus block or blocking of this particular brachial plexus nerves. So, this is the two things which is important to this particular brachial plexus in this particular domain or these particular regions. Now, coming to the arteries that we have to understand in this particular upper limb, especially in this particular upper arm. So, we have a artery which is coming from the subclavian artery, which moves to this particular axilla as axillary artery. Axillary artery moves down to this particular brachial region, we call them as brachial artery. Now, this brachial artery gives a like major branch which goes to the posterior part of the arm, we call them as profunda brachii artery or deep artery of the brachii. And then we have this like a brachial artery going down, splitting into two terminal branches, radial artery and ulnar artery. We have seen these particular branches, and these particular radial ulnar branches may have interosseous branches, and eventually radial and ulnar arteries branches go and make a kind of network of anastomosis which is present in this particular palm region. We call them as palmar arch. They are two level palmar arch, one is at the upper level and one is at the lower level. So, we call them superficial and deep palmar arch. So, this is how this particular entire arterial network present in this region. So, this particular brachial artery, you can see that this is a single artery which is running in this particular arm region between these particular muscles like biceps brachii, brachialis and this coracobrachialis, and we seen this particular artery present in this particular region. Now, this particular artery is the sole arterial sources to this particular arm and forearm. So, everything and anything problem with this brachial artery, beyond that particular problem we have a deficiency of the blood supply if you do not have this particular survival collaterals, which is a collateral or backup branches, just like a backup roads which is present in this particular joints, like in the shoulder joint, in the elbow joint and the wrist joint, they have bare brick arteries. So, this is the network of the arteries that we have seen there. Now, occlusions of the arteries that commonly happens in this particular regions, in the arm region, if it is happening, there are some clinical problems arising out of this. So, for example, if you have this particular brachial artery blocked over here in this region before the collateral. So, for example, if you have an injury over here, this brachial artery is compressed over here before this collateral. So, no blood will be flowing through this particular main artery, neither to the collateral, and no blood will be dropping down to this particular arm below down. Now, if we have a cut of blood supply to this particular arm and the forearm region, we have a condition we call them as ischemic damage. Ischemia means we have a less oxygen, less nutrients that reaching we have a deficiency of the blood flow, we call them as ischemic injury or ischemic damage. Now, if this particular ischemic damage, if have a profound effect, for example, it may have an ischemic damage for 1 hour, or it may have a ischemic damage of 10 hours. So, definitely the 1 hour damage and 10-hour damage or ischemic damage of this particular like the muscles and the soft tissue are not that same. So, if you have a 10-hour less blood supply, it is going to have a more profound effect. So, then we have this ischemic damage which is more or very more in this particular region. Now, what happens if you have a prolonged deficiency of the blood flow, the muscles atrophies. That means the muscles fibers gets damaged, and this particular muscle fiber damage becomes like a very significant and it cannot recover back. So, we call them as irreversible phase of ischemic damage. That means it cannot be reversed. Now, what happens if you have a irreversible muscle injury? The muscle fibers are forever lost, and that particular muscle fiber is replaced by collagen tissues or collagen strands. That means the muscle fiber do not have any flesh. It is only string-like structures. So, we call this particular condition as ischemic muscular injuries. And if you have a strings of collagen fibers which is replacing the muscle fiber, it is going to shrink and the arm is going to bend. So, that particular thing we call them as ischemic injuries, and this is described by a physicist or this physician which is known as Volkmann. So, this particular Volkmann, which is like a Jew physician, who just like described this particular thing about these lacerations of these particular brachial arteries, and observed that if it is prolonged observation of this particular like ischemic damage, this muscle is damaged forever and replaced by this particular scar tissue which I am telling about, the collagens and the connective tissue fibers, leading to the shortening which is permanent of the muscles and leading to the contracture like this. So, we call them as Volkmann ischemic contracture. So, this is one of the phenomena that happens. Now, this is one time it can have an occlusion of this particular blood flow if you have a damage to the artery itself. This is one thing that can happen. Other thing that can happen involving this particular arterial blood flow, we call them as compartment syndrome. We call them as compartment syndrome. So, what is a compartment syndrome? You see this particular cross section picture in the arm and cross section picture in the forearm. In the forearm, we have these two like bones there, and arm we have single bone. Now, this particular two bones you see that which is present in the forearm, having this particular two bones on the radial side and the ulnar side and intervened by the membrane, we call them as interosseous membrane, and this particular lateral and medial like fascias which is known as septas is making this particular region into two compartments, anterior compartment and posterior compartment. So, we have seen that dissection on the previous day. So, we have done the forearm front side, right. So, this particular regions in the forearm have got two compartments and it is densely packed with the muscle. So, many muscle fibers are there. In this arm region, we have less muscle fibers, but still this is way packed region along with the very tight compartment. Now, in this particular compartment, especially in the forearm, if you have an increase of pressure, how an increase of the pressure can happen? If you have a rippage of this particular blood flow here and blood is released within this particular compartment, if you have pus accumulation there in this region, if you have something foreign body have entered to this and created an infections, and if it is hugely swollen. So, if you have an extra pressure within this particular compartment, that is going to cram the blood vessel, that means going to collapse the blood vessel. So, blood cannot flow through it, that going to collapse these nerves which is going through. So, this particular phenomenon where we have increased pressure within a compartment which is occluding the blood flow and the nerve functioning, we call them as compartment syndrome, which happens if you have a broken bone leading to the blood release in this compartment. It may have a pus or fluid accumulation. It may be acute or may be chronic. That means it may have happened suddenly or may have slowly building up. So, if this particular compartment is compressing this particular vessels and the nerves, that nerves and the muscles are not going to work, that leads to this particular phenomenon. We call them as compartment syndrome, acute or chronic. It may happen in the leg compartment as well, which is also very densely tightly compartment. So, this particular compartment syndrome is increase in intra-compartment pressure compressing the nerves and blood vessels. No blood is flowing through, resulting in the same thing. The muscles and these tissues are not going to receive the blood flow through it and leading to these particular problems. We call them as compartment syndrome, ischemic damage. So, the same thing can happen with this particular problem, either blood flow obstructions by these lacerations or this particular compartment or in compartment pressure rise that can lead to this particular ischemic contracture or Volkmann ischemic contracture. So, these are the two things about compartment syndrome and Volkmann ischemic contracture. So, this is what basically both of the situation can lead to this particular contractions, either loss of blood because of this particular blood is not flowing through, or intra-compartment pressure rise can lead to these particular same situations. We call them as Volkmann ischemic contracture. All right. So, it may be like a little bit like difficult for you to digest at this particular moment about this particular compartment syndrome and this Volkmann ischemic contracture. Just like do read this particular thing, understand as much as you can, is fine. Again, in the lower limb, again we are going to come back with the compartment syndrome. Again we will narrate and again we will explain this particular element again. Now, if you have a bleeder which is present in the upper arm, which is coming from the artery, which is brachial artery. This is only one artery there. So, if you have a gunshot injury or knife injury which is hit this particular artery, now we have to stop the bleeding by pressure or compressing that. So, this particular region, in this particular midshaft region, this particular artery or brachial artery can be compressed, pressing on the humerus and lifting this particular biceps brachii. So, you have this biceps muscle which is present in here. So, you have to lift this particular biceps muscle laterally, that means upwards and move it laterally. Pull it and pull it laterally, then you can get a space where you can free this particular artery which is flowing through, and you can compress this particular artery with the other hand on this particular bone. So, whenever you are going to achieve some kind of hemostasis or stoppage of the blood, you have to press that artery against some firm or hard substances, where this you can press it on something substantial. So, where you are going to get something firm, the bone is the only thing that you get this thing self-form. So, this artery needs to crammed by pressure externally by pressing on this particular region. Where it can be pressed in this around this particular region, we call them a spiral groove which is present in this midshaft region, and we have to pull this particular biceps up, and then we get this particular like a hollow region, then we can press this particular tissue over this particular brachial artery onto this particular midshaft of the humerus and control the hemorrhage which is happening in this particular arm region. So, if you can achieve this particular hemostasis here, if you have a bleeder down somewhere in this elbow region, we can achieve a hemostasis. This is one occlusions of the brachial artery. Other occlusions of brachial artery, we do that while measuring this particular blood pressure. This is what we do, right? Putting a cuff over here, just like put a kind of like a cuff with the inflator, and then we just like release it slowly to measure this particular blood pressure. This is what we do that in this particular region in the cuboidal fossa, and we understand this particular cuboidal fossa have got this particular structures which is present in this region, TAN, tendon, artery and nerve, and we know that where exactly we are going to place this bale of the stethoscope in this particular domain. So, we have to identify the tendon of this particular biceps brachii, then next to this particular thing which is lying medially, the artery. So, this particular area we have to put this particular nerves over there. And in the cuboidal fossa, we have a cutaneous vessel which is present in here. We call them as medial cutaneous vein or antecubital vein, which is used for drawing the blood on or from this region. So, this is what about this particular region of the brachial plexus occlusions over this region. Now, coming to the nerve injury in this particular region of this femur domain. Humerus domain. So, this particular humerus is having like a close association of the few nerves. In the neck region, it has an association of the nerve which is known as axillary nerve. So, if you have a surgical neck fracture by any chance, it can cramp this particular axillary nerve and this particular nerve cannot function. So, the nerve which is supplying the muscles are not going to work. That is what is going to happen, like the axillary nerve and as well as this deltoid and the teres minor is not going to work. If you have this particular midshaft fracture which is going to cramp this particular nerve which is known as radial nerve. If you have radial nerve damage, anything on the back side is not moving. So all the back muscles like starting from the arm, forearm, all are supplied by this particular radial nerve. So resulting in wrist drop. So this particular wrist cannot be lifted up, we call them as wrist drop. So in this region, if you have this particular medial condyle of this particular humerus fractured, here we have this ulnar nerve. So again, if you have an ulnar nerve damaged in this particular broken segment, may have this particular same problem, we call them as claw hand. So this particular claw hand, we have a problem with this. If you have this particular problem, we call them a supracondylar fracture, which is kind of like a very significant problem. I would say this what happens in case of the kids where this supracondylar region may have injuries. It may going to trap this particular artery, which is brachial artery, may trap this particular nerve which is present in front of. So nerve and artery together can get cramped over this particular supracondylar fracture. So if this particular nerve is going to cramped, then median nerve is not going to work. That forearm muscles and the hand muscles are not going to work. The arteries, if it is occluded by this, we know that this is going to have this ischemic damage, that Volkmann ischemic damage or ischemic injury that is going to happen in case of this neurovascular injury in the supracondylar fracture. So these are all your exam questions that you need to focus on these particular bones over here and prepare accordingly. Get this particular humerus, identify these different parts, shaft of the humerus like spiral groove, then we neck of the humerus like this, medial epicondyle like this, and supracondylar region like this, and what are the neurovascular structure or vascular structures that may get like a damaged if you have fractures related to that particular part. This is what we are talking about. Entrapment of the axillary nerve which is present in weakness of the deltoid teres minor. If you have a fracture in this particular region which is known as the surgical neck of the humerus. So this is how, this is what we have to prepare related to this particular clinical questions. Now coming to this particular other clinical thing related to this particular region, we call them as like a tapping this particular nerve reflex. Sometimes we have to judge that whether the nerves are working fine or not. So we call them a spinal tap reflex test. So we find this particular biceps brachii tendon, we put a finger and do a neurological hammer test, like we strike that particular tendon correctly, like sharply, and we stimulate this particular biceps brachii muscle. Now this bicep brachii muscle will be just like doing a sudden flexion. So with this particular sudden flexion, we call them as elbow flexion, which is indicating a healthy biceps brachii muscle and its nerve supply. That means musculocutaneous nerve and as well as this particular biceps brachii muscle itself doing a healthy function, as well as the nerve segment, that means spinal cord segment, where from this particular biceps brachii receiving the innervations like a C5, C6 domain, that means in the high up in the brachial plexus, that part also working fine. So this is what we call them as tendon reflex. So when you go for this particular physiology, neurological examination, they will go for this particular neural examination like a hammer test, or this we call them as superficial tendon jerk reflex. So that particular superficial tendon jerk reflex, again you have to know this anatomy, like where you are going to find this tendon of the biceps brachii in the cubital fossa, how we are going to identify that, and then you have to tap it. So this is what clinically matters to us. Coming to the nerve injury that we have just mentioned about, the ulnar nerve injury. Ulnar nerve injury can happen in this particular region like supracondylar, that's like medial epicondyle injuries in here. We have seen this ulnar nerve dissected out in the wrist joint on the ulnar side yesterday. So this particular deep injury on this wrist joint which is involving this particular region can have a damage on the ulnar nerve. Also, ulnar nerve can be getting trapped over this particular region. We call them as cuboidal tunnels, where this particular ulnar nerve going under to this particular tunnel, going on top of this particular region, above this particular flexure reticula. So these are the point where this particular ulnar nerve injury can happen. If you have ulnar nerve injury, we have the clinical condition, we call them as claw hand. So what is a claw hand? This particular individual, whenever they are trying to make a fist, they make a claw because of the short finger muscles are not working. So this is, we call them as partial claw hand. So this particular injury leading to the flexion and adduction injury in the shoulder joint, in this particular like a wrist joint region. So when you go learn on this particular small muscles of the hand and their innervations, this particular explaining this particular ulnar nerve injury to this particular to this particular claw hand deformity will be easy for us to do it. So, I am not just like spending time on this like ulnar nerve and a claw hand deformity right way, just explaining that ulnar nerve injury leading to the claw hand deformity, which is because of this particular nerve which is going to supply the small muscles in the hand. Other injury which is easy to comprehend, that we call them as radial nerve. So, which has a long course supplying all the muscles in the back region, forearm, arm, everything in the back region supplied by the radial nerve. So, this radial nerve can have injuries in the different locations. It can have a location injury in this particular region, we call them a spiral groove. It can have injuries in this particular fractures of the spiral groove or this particular clutch which is maybe pushing in this particular region as well. So, resulting in radial nerve injury, the wrist drop. That means all the muscles of this particular back side is doing this extension work. So, all the forearm muscles in the front side, they are doing the flexion. So, this particular flexion part will be there, extension will be absent, resulting in, we call them as wrist drop, or this particular wrist cannot be lifted up. So, it will be flexed, it cannot be lifted up. So, extension of the wrist joint is not possible if you have a nerve injury which is known as radial nerve injury, because that is going to supply this all the muscles in the back region. So, this is in short about this particular clinical aspects of these things that we have covered so far, apart from this particular shoulder joint which is already been covered so far. So, just like a study through these particular clinical problems in the weekend, try to have an idea about, it's not that reading one or twice you can get of all the idea concrete in your brain and understand everything. It's not possible. It takes time to comprehend and understand things. Bit and bit you will understand, bit you don't. Some things you may have understood well, maybe have not well understood. Then you can just like come and cross talk and keep on talking and discussing, then you can understand what the problem is going on. And again you may be forgetting about these things what we are saying, because it's easy for us to just like go on telling you this is happening, but for you, you haven't seen a patient, you haven't experienced this particular element at all. So, it's going to be difficult. So, slowly you just like absorb it as much as you can, just like then let go, then again come back and read that again. All right.